Imagine you're sitting in an examination room, just taking a routine medical history from a brand new patient.
Right, just a standard intake.
Exactly. And suddenly, like mid-sentence, the patient abruptly stands up from their chair, pauses for maybe a fraction of a second, and sits right back down.
Okay.
And a few minutes later, they do it again. The movement is perfectly executed. I mean, it looks completely intentional.
Mm-hmm.
But when you ask them why they keep standing up, they look deeply uncomfortable.
Yeah, they usually do.
And they tell you they simply couldn't stop themselves.
So, okay, let's unpack this. What are you looking at? Is this like a behavioral quirk? Is it a psychiatric compulsion? Or is it the first terrifying whisper of a degenerative brain disease?
That is the big question.
It is. Welcome to the deep dive. Today we are turning this space into a clinical teaching hospital. And you, listening right now while you're doing rounds with us today, we are tackling the deeply complex world of motor tics and chorea. A fascinating topic, honestly. So fascinating. And by the time we finish, you're going to understand how to look at an abnormal movement and decode exactly what is misfiring in the human brain.
Which is, I have to say, an incredibly vital skill. In medicine, distinguishing between different types of abnormal movements isn't just, an academic exercise.
Right, it has real consequences.
Massive consequences. If a physician misidentifies a tic as chorea or a myoclonic jerk as a tic, they are immediately led down the completely wrong diagnostic path.
They're looking at the wrong map, basically.
Exactly. They start investigating the wrong underlying systemic issues, pointing to the wrong anatomy, and most dangerously, prescribing the wrong treatments.
Which could actively harm the patient.
Precisely. The diagnostic landscape of neurology isn't like, it's not like looking at a fractured bone on an X-ray. It's a puzzle of observation, patient history, and really understanding the deep underlying chemistry of the body.
Yeah, it's real detective work. It really is. So, by the end of our rounds today, you'll understand the clinical features, the etiologies, meaning the root causes, and the differential diagnoses of these complex movements.
So let's step right into our first clinical case scenario. Let's set the stage here. Sitting on the exam table is a 45-year-old patient.
Okay, middle-aged.
Right. You're taking their history, just observing their resting posture. And out of nowhere, they exhibit this sudden, rapid brow wrinkling. The muscles in the forehead contract violently and then release.
And then what?
Well, a few minutes pass. Then there's a distinct facial grimace, pulling the corner of the mouth down, and then an occasional abrupt shoulder shrug.
Okay, so as the attending physician in this room, your eyes are immediately isolating the nature of these movements. What stands out physically?
They're sudden, right, and rapid.
They are sudden, they are rapid. But crucially, they resemble purposeful actions. I mean, a shoulder shrug is something we do naturally to express uncertainty. Brow wrinkling expresses confusion.
Yeah, like you're reacting to something.
Yeah. Right. But in this room, devoid of any conversational context, happening repeatedly and rapidly, it is distinctly abnormal.
The thing that makes this specific scenario an immediate red flag, though, is the patient's age. This is a 45-year-old adult.
Which changes everything.
Exactly. If a 7-year-old was doing this, we might instantly think, oh, Tourette's syndrome. But with an adult, the diagnostic net has to be thrown incredibly wide.
Very wide.
Is this a bizarre side effect from a medication they just started? Is it the subtle early warning sign of a hidden brain injury? Or maybe a stroke?
This raises an important question, and it's the exact pivot point of the clinical reasoning here. When faced with an adult presenting with what appear to be new motor tics, your diagnostic algorithm has to start with one specific question.
Before you do anything else.
Yes. Before you order an MRI, before you draw a single vial of blood, you must ask, is there a history of childhood tics?
Wow, okay. Because Tourette's syndrome, which is the most common cause of motor tics, almost exclusively begins in childhood.
That's the key.
So if this 45-year-old says, oh yeah, I used to blink constantly when I was in 3rd grade, that completely changes the trajectory of the investigation.
It completely changes it. The medical literature is explicitly clear that Tourette's can go into complete remission. The neurological pathways responsible for those childhood tics can essentially go dormant.
Just totally power down.
Exactly. A patient might not have experienced a single tic for 3 decades, but under stress or simply due to the natural aging of the brain, those pathways can reactivate later in life.
That's wild to think about.
It is. If you fail to ask about their pediatric history, you might spend thousands of dollars looking for a tumor or an environmental intoxication when the answer was buried in a third-grade memory.
That makes perfect sense. You basically have to rule out the ghost of their medical past before you start hunting for new diseases.
Exactly right.
But let's step back for a second and actually define what we are looking at. Let's dig into the anatomy and physiology of a tick. Because when we say keratic, I think most people just picture a localized twitch, like an eyelid jumping.
Right, which is a common misconception. But the clinical texts show us they exist on a massive spectrum. We define motor tics as sudden, rapid movements that, to varying degrees, resemble purposeful actions.
Okay.
The spectrum begins with what we call simple tics.
Which would be exactly what our imaginary patient was doing, right? The brow wrinkling, the facial grimacing, the head shaking, just single isolated muscle groups firing in a discrete burst.
Correct. But then the spectrum extends to complex tics. These are coordinated, sequenced movements that involve multiple muscle groups acting in concert.
Like what?
Well, it could be a specific series of hand gestures, touching objects, or, as you mentioned at the very beginning of our rounds, literally rising from a chair.
Oh, right. The patient standing up.
Exactly. The more complex the tic, the more easily it is misinterpreted by observers as deliberate, conscious behavior.
And we also have to map how these movements present geographically across the patient's body, right?
Right.
The clinical distinction here is between focal tics and multifocal tics.
Yes, mapping is crucial.
If I understand the terminology right, focal means the pathology is locked to one specific location,
Right.
like the exact same tic in the exact same spot, recurring over time.
Yes, a single, unchanging geographic presentation. But the text notes that in the vast majority of cases, tics are multifocal.
Meaning they jump around.
Basically, yes. You will see different elliptics occurring at different locations on the body, a facial grimace 1 minute, a shoulder shrug the next, perhaps an abdominal contraction after that. The misfiring signal in the brain is migrating, finding different motor pathways to exploit.
But here's the critical challenge for the diagnostician. How do we know definitively that this brow wrinkle is a true verlic and not just a random muzzle spasm?
That's where you have to look for the hallmarks.
Right. The medical literature gives us two pathognomonic features. These are the hallmark signs, the absolute North Star for identifying a tic. If you don't see these two features, you are likely looking at a different movement disorder entirely.
And those two features are the premonitory urge and temporary suppressibility. We need to explore the physiological mechanics of both, starting with the premonitory urge.
Okay, lay it on us.
This is not a physical movement. It is a profound sensory experience for the patient. It is an internal feeling, a rising physical tension that builds within the body.
Like a pressure.
Exactly like a pressure. It escalates in intensity, creating a deep, almost unbearable discomfort until it is finally and only relieved by the actual execution of the tic.
It's like a neurological itch that cannot be scratched by anything other than that one specific movement.
That's a great way to put it.
And that leads directly into the second feature. Temporary suppressibility. This means the patient actually has the physical ability to stop the ticking from happening. They can hold it in.
They can, yes.
But doing so isn't just some passive decision. It requires massive, exhausting willpower.
It is an active, strenuous suppression of an overwhelming physiological drive. The basal ganglia, the part of the brain that acts as the gatekeeper for our movements, is just screaming for release.
And the brain is trying to stop it.
Right, the frontal cortex is desperately trying to keep the gate closed.
The primary source text uses an absolutely brilliant analogy to explain this, referencing a prominent neurologist from 1928 named Kinnear Wilson. He perfectly captured this agonizing dynamic.
Oh, the sneezing analogy, it's brilliant.
Yeah. He wrote that, quote, "The strain in holding back is as great as the relief in letting go." And he reported that his patients described the experience by saying, "You cannot help it any more than you can sneezing."
The sneezing analogy is neurologically profound. Think about the physiological cascade of a sneeze. You are sitting in a silent room, perhaps a theater.
The worst place to sneeze.
Right, and you feel that profound, localized tickle deep in your sinuses. That is your premonitory urge. As the seconds pass, that tickle evolves into an overwhelming physiological demand.
The pressure builds.
Yes, and you can clamp your mouth shut, you can hold your breath, you can temporarily suppress the reflex.
But the strain is immense. Your eyes water, your heart rate might even spike slightly. You are literally fighting your own nervous system.
Exactly.
And eventually the physical tension shatters your willpower, and the sneeze forces its way out, bringing immediate, localized relief. That is exactly what a patient with a motor tic is experiencing, just in a different muscle group.
That is the exact mechanism.
I have to admit some philosophical confusion here, though. If a patient can physically stop the movement, even if it's only for a few minutes, I mean, if they can consciously choose to hold it in, why does the medical community classify this as an involuntary movement disorder? It sounds a lot like a conscious compulsion.
That boundary between involuntary reflex and conscious action is exactly what makes motor tics so fascinating to neurologists. The boundary is heavily blurred.
It really seems like it.
We classify them as involuntary because the urge itself, that rising, overwhelming neurological tension, is entirely out of the patient's control. They do not choose to feel the urge.
Oh, I see.
The actual physical movement, the release, is essentially a capitulation. It is a technically voluntary motor action executed specifically to relieve an involuntary, unbearable sensation.
Wow. The brain is essentially holding the body hostage until the body performs the movement to relieve the pressure. That is a brilliant way to understand it.
It really paints a clear picture.
Now, I want to pivot our approach. Since we are doing clinical rounds, we need to map this out visually. We're going to build some functional mental models. Let's trace the actual pathways of this pathology so you can see the mechanics in your mind's eye.
Visualizing the physiological process is simply the best way to move from memorizing a list of symptoms to truly understanding how a disease operates.
Exactly. So let's start with the physiological life cycle of a ticket. Picture a timeline. On the far left, we have the trigger. This could be stress, fatigue, or just a random neurological spark.
And that trigger initiates the premonitory urge.
Right. Visualize this as a line on a graph starting at 0 and curving sharply upward. That rising line represents the agonizing physical tension building in the patient's nervous system.
And as that tension line rises, the patient actively engages the next phase, which is temporary suppression. They are consciously applying the brakes.
Fighting it.
Right. But the tension curve underneath those brakes is still climbing. The physiological pressure is compounding.
Until the brakes fail. The graph hits its peak, leading to the motor tic execution, the dam breaks, the brow wrinkles, or the shoulder shrugs.
Yes.
And immediately following that movement, the tension curve plummets back down to 0. That is the phase of temporary relief. So it's trigger, urge, suppression, execution, relief.
Yeah.
That is the invisible cycle happening inside your patient every few minutes.
Spot on. Now, let's look at how anatomy dictates the presentation. We discussed focal tics earlier. Let's trace the pathway of a very specific etiology mentioned in the text, which is a peripheral injury tic.
Okay, so we have a patient who suffered a physical trauma. The text gives the example of an injury to the neck, like severe whiplash from a car accident. How does a mechanical injury in the neck turn into a neurological movement disorder?
It starts right at the site of the damage. The peripheral nerves in the neck have been injured. Instead of healing cleanly, those damaged nerves begin sending continuous abnormal sensory signals up to the brain.
So they're basically broadcasting a localized distress signal.
Yes, a constant neurological static. The brain receives this constant sensory static from the neck and it misinterprets it. It generates a premonitory urge specifically localized to that area of distress.
Oh, wow.
And because the sensory signal is strictly tied to the cervical anatomy, the resulting motor response, the tic, is also strictly confined to that same anatomy.
So you end up with a persistent head or neck jerk that is isolated entirely to the proximity of the original physical injury. It won't suddenly jump to the patient's hand or foot.
Exactly, because the brain is only trying to relieve the tension exactly where the static is originating.
That structural logic is incredibly satisfying. But now we have to scale up to the hardest part of the clinician's job, figuring out the underlying cause when there is no obvious injury.
This is where it gets tough.
Right. So let's build the diagnostic flowchart. This is the decision tree you run through your head when our 45-year-old patient from the beginning is sitting in front of you.
This is your algorithm for survival in the diagnostic landscape.
So at the top of our flowchart, we have our starting point. Motor tic observed. We verified it has the urge and the suppressibility. We draw a line down to our very first major decision gate, which we discussed earlier, childhood history.
And if the patient answers yes, your diagnostic path branches off cleanly. You are almost certainly looking at Tourette's syndrome or chronic motor tic disorder that has recurred. You investigate those pathways.
But if they say NO, they've never had a tic before in their life,
Right.
well, the flowchart drops down into a much more complex territory. The next major gate is check medication history. Are they taking stimulants, anti-epileptics, antidepressants, or antipsychotics?
If the answer is yes, you must pause and evaluate the neuropharmacology. Could this drug be altering their basal ganglia?
And if the answer is NO-like, their medicine cabinet is completely empty. Your flowchart plunges deeper. The next gate is to check for underlying systemic coriform disorders. You are looking for massive, life-altering diseases like Huntington's.
And if those tests all come back negative, you hit the bottom of the flowchart. Investigate miscellaneous causes. This is where you are hunting for carbon monoxide poisoning, old brain injuries, or lingering viral infections.
It's just a systematic process of elimination.
It is. And that elimination process brings us to the most labor-intensive phase of our rounds, the etiology, the detective work. When that childhood history gate is an NO and you have to investigate medications and systemic causes, you need to understand exactly how these external factors are breaking the brain's motor control.
Let's start with the medications. Here's where it gets really interesting. I want to look closely at the drugs that can induce motor tics because the variety is staggering. The text categorizes them beautifully. First up are the stimulants.
Right.
This makes intuitive sense. We are talking about illicit drugs like cocaine, but also heavy pharmaceutical prescriptions like methylphenidate, pamela, and etomoxetine.
The mechanism here is relatively straightforward. Stimulants flood the central nervous system with neurotransmitters like dopamine and norepinephrine.
Giving it a ton of energy.
Exactly. They essentially press the accelerator on the entire nervous system. When you flood the basal ganglia with too much dopamine, the motor pathways become hyperexcitable. The brain starts generating movement signals tics simply because the system is over-revved.
Too much fuel in the engine.
Precisely.
But the next category in the text feels completely paradoxical to me. Anti-epileptics. Drugs like lamotrigine, carbamazepine, and phenobarbital. If a patient is taking a drug specifically designed to suppress electrical misfires in the brain and stop seizures, how on earth is that same drug causing an electrical misfire that results in a tic?
That is the brilliant paradox of neuropharmacology.
It really is a paradox.
The brain is an incredibly delicate balance of excitatory signals saying go and inhibitory signals saying stop. Anti-epileptics broadly suppress neurological activity to prevent the massive electrical storms of a seizure.
Right.
But in doing so, they can sometimes disproportionately suppress the brain's inhibitory pathways.
Oh. So by trying to calm the whole brain down, the drug accidentally knocks out the specific brakes that normally prevent epitics from happening.
Precisely. The overall electrical activity might be lower, but the specific regulatory oversight of the motor system has been compromised, allowing these discrete motor tics to slip through the cracks.
That is fascinating. It's basically like turning off the security system while trying to dim the lights.
That's a great analogy.
The text also lists antidepressants as culprits, specifically SSRIs like escitalopram, sertraline, and fluoxetine, as well as tricyclics like clomipramine. Altering serotonin levels can apparently destabilize motor control as well.
It certainly can.
But we need to spend some serious time on the heavy hitters, the antipsychotics, drugs like haloperidol, thiordazine, and clozapine.
This is a diagnostic trap that catches many clinicians off guard. The text specifically highlights a condition called tardy Tourette's.
Tardive meaning delayed or late appearing.
Yes. It is a subtype of tardive dyskinesia. Antipsychotics primarily work by blocking dopamine receptors in the brain to reduce hallucinations and delusions.
Right, starving it of dopamine.
Exactly. But when you block those receptors for years, the brain tries to compensate. It thinks, I'm not getting enough dopamine signals, so it creates more receptors, and those new receptors become incredibly hypersensitive.
The brain is starved for dopamine, so it basically turns up the volume on the receivers to catch whatever it can.
Exactly right. And eventually, this hypersensitive state in the basal ganglia manifests as sudden, uncontrollable motor tics. But here is the critical warning from the medical literature. A massive amount of time can elapse between the patient starting the antipsychotic and the emergence of the tics.
So a patient can be sitting in your office, presenting with a brand new facial tic. You look at their chart, see they've been on haloperidol for 6 years with absolutely no side effects. And your instinct might be to assume the drug is safe and look for another cause.
And that instinct would be dead wrong. You have to recognize that the neurological adaptation, the slow upregulation of those dopamine receptors, has been quietly compounding in the dark for 6 years.
Wow.
The Tanatic today is just the final breaking point of a process that started half a decade ago.
It's literally a delayed fuse. Okay, so we've investigated the medicine cabinet. What if the patient is on 0 medications? The flowchart tells us we must look for coriform disorders next.
Which is a heavy diagnostic step.
Yeah. Now, we are going to dive deeply into chorea in just a moment, but the text makes a crucial point about how Torrentics and chorea interact.
It does. We traditionally view a torrentic and chorea as two entirely separate types of movement. But the literature explicitly states that true motor tics can occur during the course of massive coriform diseases.
Right. It specifically lists Sydenham's chorea, Huntington's disease, and neuroacanthocytosis. For neuroacanthocytosis, it states that over half of the patients will eventually develop chorionics alongside their other symptoms.
And diagnostically, the most terrifying fact hidden in the text is that these severe, often terminal degenerative diseases can actually present with a simple tic as their very first clinical sign.
Meaning, before the patient develops the classic, sweeping, uncoordinated movements of Huntington's, before they show any severe cognitive decline, the very first whisper of the disease might be a simple, suppressible shoulder shrug.
It's sobering.
That is a huge burden for a diagnostician.
It is, and it emphasizes why you can never simply dismiss a new movement disorder in an adult. You must run the differential to the very end.
Speaking of running it to the end, let's look at the miscellaneous wildcards. If it's not Tourette's, not a drug, and not Huntington's, what environmental or systemic disasters can cause a tic? The text lists carbon monoxide poisoning.
Yes. Carbon monoxide specifically targets and damages the highly oxygen-dependent tissues in the brain, particularly the basal ganglia.
The motor control center.
Right. When that tissue dies or is severely compromised by hypoxia, the motor regulation fails, resulting in tics.
The text also mentions post-encephalitis cases, specifically highlighting herpes zoster and varicella zoster.
Those are the viruses responsible for chickenpox and shingles. In rare cases, those viruses can cross the blood-brain barrier and cause encephalitis, which is massive inflammation of the brain tissue.
And what happens after?
When the inflammation subsides, it leaves behind scarred neural pathways. If that scarring occurs in the motor centers, you are left with post-viral tics.
It is incredible how a childhood case of chickenpox could theoretically lay the groundwork for a neurological misfire decades later.
The brain remembers everything.
It really does. The text also lists infarction of the basal ganglia. An infarction is essentially a localized stroke, right?
Yes, exactly.
A blood clot starves a tiny piece of the brain's movement control center, and suddenly the patient develops a focal tic. We also see rare metabolic and structural issues like pantothenic kinase-associated neurodegeneration and Behçet syndrome. The list of potential culprits is just exhaustive.
Which brings us to the absolute core of clinical diagnosis, the differential diagnosis. We have discussed what causes a tic. Now we must discuss how to prove that the movement you are observing is actually a tic and not an imposter.
The rule-outs. Our source text gives us 4 specific movement disorders that brilliantly mimic a motor tic to the untrained eye. If you don't know the deep physiological mechanics, you will misdiagnose them.
And we can't have that.
No, we can't. Let's walk through these 4 mimickers, starting with the first one, myoclonus versus a tic.
A myoclonic jerk is a sudden, brief, shock-like contraction of a muscle. If you just glance at a patient, a myoclonic jerk of the shoulder looks identical to a simple shoulder tic.
So how do you tell them apart? The text says it all comes down to the physical quality of the relaxation.
Exactly. You must closely observe the milliseconds immediately following the movement. A tic is an autonomous motor program being executed and then instantly shut off. It fires and it stops.
Just boom, done.
Right. There is no wind down. Myoclonus, however, is a raw electrical misfire in the nervous system. And because of the nature of that raw electrical surge, it is characterized by a distinct, observable, slow relaxation phase.
Oh, interesting.
The muscle jerks violently, and then you can physically see it slowly, smoothly returning to its resting state as the errant electricity dissipates.
So a tic snaps shut while myoclonus slowly fades out. Furthermore, the text reminds us that myoclonus has 0 premonitory urge and 0 suppressibility.
Yeah.
The patient doesn't feel it coming, and they cannot stop it. It's just a raw short circuit.
That's a perfect summary.
Okay, mimicker number 2, chorea versus a tic. This is the big comparison.
It is. Coriform movements can also be simple or complex, and just like tics, they can resemble purposeful acts. But the physical texture of the movement is entirely different. The text describes coriform movements as displaying an almost lightning-like fluidity.
Mercurial is the word the text uses. They appear and reappear at different sites across the body in a continuous flowing fashion. I think the best way to visualize this is to think about the flow of energy.
Go on.
Chorea is like water flowing unpredictably through a complex plumbing system. It is fluid, it is continuous, it surges into the arm, then ripples across the chest, then flows into the leg in a mercurial, unpredictable wave.
That is a perfect physical description.
Whereas a tic, by comparison, is like a sudden high-pressure valve bursting open for a split second, releasing a blast of steam and then snapping violently shut. It is a discrete, explosive, isolated event. It does not flow.
Fluidity versus a discrete explosion. And again, chorea lacks the urge and the suppressibility. A patient with chorea cannot hold the water back no matter how hard they try.
They're just at its mercy.
Right. Now, let's examine the third mimicker. Hemifacial spasm versus a tic.
This one is tricky geographically. A hemifacial spasm is a twitching in the face. A tic can also be a twitch in the face. If you are staring at a patient's twitching cheek, how do you differentiate the underlying cause?
You have to rely heavily on your anatomical knowledge. A hemifacial spasm is typically caused by a physical compression of the facial nerve, cranial nerve 7th, usually by an aberrant blood vessel pressing against the nerve as it exits the brainstem.
Okay.
Because the pathology is strictly tied to that specific nerve, the resulting spasm can only involve the musculature innervated by cranial nerve 7.
And because the left facial nerve only controls the left side of the face, and the right controls the right.
The spasm is rigidly confined strictly to one side of the face. It will never cross the midline.
Never.
Never. A facial tic, however, originates higher up in the brain's generalized motor pathways. It might involve muscles outside the facial nerve's domain, like the jaw or the neck, and it can easily occur bilaterally, involving both sides of the face simultaneously.
That's a huge clue.
It is. If the twitching is rigidly locked to one side, repetitive, and devoid of any premonitory urge, your diagnosis points toward a structural compression of the facial nerve, not a cytic disorder.
Anatomy provides the absolute answer. Okay, the fourth and final mimicker. Tip douloureux versus a tic. Now, this one feels almost like a trick question because it literally has the word tic right there in the name.
It is one of the more unfortunate misnomers in medical history. Tic douloureux is an older term for a condition characterized by incredibly severe, sudden spasms of the face.
And what causes it?
It's almost always associated with trigeminal neuralgia, an intense inflammation or compression of the trigeminal nerve which handles pain and sensation in the face.
But our baseline rule from the text is incredibly clear. Tics are not painful. The premonitory urge is uncomfortable, it is agonizingly tense, but it is not an acute, sharp pain.
Exactly. So when you observe a patient with tic douloureux, what you are seeing is not a true autonomous motor tic. The patient experiences a sudden, unannounced bolt of excruciating, lightning-like neurological pain firing through their jaw or cheek.
Oh, wow.
The movement that follows is merely a violent, reflexive wince in reaction to that severe pain. They wince because it hurts, not because an involuntary motor pathway is forcing a release.
The distinction is critical. One is an autonomous motor program seeking tension relief. The other is simply a human being flinching in agony. You basically just have to ask the patient what they felt right before the movement.
That's the clinical reasoning right there.
Okay, since we just spent a massive amount of time using chorea as a differential diagnosis, comparing the bursting valve of a tic to the fluid mercurial water of chorea, we really need to transition and truly understand what actually causes that fluid movement. We need to expand our medical lexicon.
We must. Because if you run your differential diagnosis, successfully rule out a tic, and determine your patient is actually exhibiting chorea, your flowchart completely changes direction. You're hunting for entirely different pathologies.
And the hunting ground is massive. I am looking at the section of our source text titled Causes of Chorea, and the sheer volume and diversity of these causes is overwhelming. It spans almost every major system in the human body.
That breadth tells you something fundamental about chorea. If we connect this to the bigger picture, it demonstrates that chorea is rarely just an isolated neurological glitch.
It's a symptom of something bigger.
Exactly. It is very frequently a profound symptom of broad systemic bodily issues. It is the brain's basal ganglia acting as an alarm bell, reacting to a systemic crisis happening elsewhere in the body's chemistry or structure.
Let's break this massive list down logically so we can actually digest it. We will categorize these systemic triggers. Category 1, medications and intoxicants. Just like tics, drugs can cause chorea.
But the list of offending agents is quite different. We do see tardive dyskinesia from antipsychotics here again, but then we see something incredibly common, oral contraceptives.
Wait, everyday birth control pills can cause a severe fluid movement disorder. How does that even happen?
It is a rare complication, but it comes down to hormonal influence. Estrogen has a complex modulatory effect on dopamine receptors in the basal ganglia.
Okay, so it messes with the balance.
Right. In certain susceptible individuals, the sudden introduction or fluctuation of synthetic hormones can disrupt that delicate balance, essentially altering the sensitivity of the motor control centers and triggering coriform movements.
The text also lists anti-seizure medications here again, like phenytoin, valproic acid, and gabapentin. We also have toxic levels of mood stabilizers like lithium and phenobarbital intoxication.
And we must look closely at levodopa. Levodopa is the gold standard pharmaceutical treatment for Parkinson's disease.
Because Parkinson's means they don't have enough dopamine, right?
Exactly.
There.
Parkinson's is characterized by a lack of movement caused by a severe deficit of dopamine in the brain. You give a patient levodopa to replace that missing dopamine and restore their ability to move smoothly.
But if you overshoot the dose,
Exactly. If you flood the system with too much levodopa, you swing the pendulum from a deficit of movement entirely into an excess of movement. You inadvertently induce chorea.
it's a high-wire active neurochemistry.
It really is.
The text also mentions baclofen, a muscle relaxant, which is fascinating because it notes chorea can happen both during the treatment and upon discontinuation of it.
Oh.
So whether you are introducing the chemical or withdrawing it too fast, the shock to the system is what causes the motor failure.
Yes. Sudden changes are always risky.
It even lists cimetidine, an over-the-counter antacid. How does an antacid cause a brain disorder?
Cimetidine is notorious for altering the way the liver metabolizes other drugs, and it can also cross the blood-brain barrier.
Oh, that's not good.
No. In high doses or in older patients with poor kidney function, it can accumulate and directly antagonize receptors in the central nervous system, leading to toxic encephalopathy and chorea.
The interconnectedness of the body is just wild. A stomach pill altering liver enzymes causing a brain misfire, resulting in a dancing movement disorder.
Welcome to medicine.
Honestly. Okay, category 2. Gradual onset in adulthood.
If an adult patient slowly, insidiously develops these fluid mercurial movements over months or years, you are primarily looking at degenerative genetic or metabolic diseases. The text lists Huntington's disease as the classic example.
What else?
Well, also Huntington disease-like syndrome type 2, chorioacanthocytosis, and McLeod syndrome.
It also highlights Wilson's disease. Now, Wilson's disease is a genetic failure of copper metabolism, right? The body can't excrete copper, so it builds up to toxic levels.
That's right.
And apparently, that copper specifically deposits into the basal ganglia, physically poisoning the motor control centers and triggering chorea. The text also interestingly lists schizophrenia and senile chorea, which is simply associated with the advanced degeneration of age. Let's move to category 3, childhood onset.
Sydenham's chorea is the historical and clinical hallmark here. This is a fascinating disease mechanism. It often follows a group A streptococcus infection, a simple case of strep throat.
How does a throat infection make a child's limbs thrash around?
Through a process called molecular mimicry, the child's immune system creates antibodies designed to attack the strep bacteria. But the proteins on the surface of the strep bacteria happen to look structurally very similar to the proteins found on the cells of the child's basal ganglia.
Oh, no.
Yes. So the immune system gets confused, crosses the blood-brain barrier, and begins actively attacking the brain's motor centers, causing severe inflammation and chorea.
The body's own defense system accidentally initiates friendly fire on the brain. That is devastating, but brilliant to understand.
It's a tragic but profound mechanism.
The childhood category also lists cerebral palsy, Lesch-Nyhan syndrome, and ataxia telangiectasia. Okay, category 4. These are the systemic and miscellaneous causes, the wildcards. This is where you truly see how the brain does not operate in a vacuum.
This list highlights how dependent the basal ganglia is on systemic stability. The text points to strokes, specifically infarction of the basal ganglia or the thalamus.
The thalamus acts as a major relay station for motor signals, doesn't it?
Yes, it does. If you destroy that relay station with a blood clot, the regulatory flow of movement is broken and chorea escapes.
The text also lists severe infectious and autoimmune conditions.
Right.
AIDS dementia, toxoplasmosis, which is a parasitic infection, progressive multifocal leukoencephalopathy, systemic lupus erythematosus, and antiphospholipid syndrome. If the immune system is fundamentally compromised or hyperactive, the brain pays the price.
The text also heavily emphasizes metabolic and endocrine crises. Hyperosmolar non-ketotic hyperglycemia, which is a state of severe uncontrolled diabetes where the blood becomes dangerously thick with sugar.
And hypernatremia, which is a massive excess of sodium in the blood, hyperthyroidism, an overactive thyroid gland pouring out too much metabolic hormone.
All of these fundamentally alter the electrical gradients and metabolism of the brain cells.
Wait, pregnancy is also on this list. Chorea gravidarum.
Yes. Similar to the mechanism we discussed with oral contraceptives, the profound, rapid hormonal shifts of pregnancy, the massive influx of estrogen and progesterone can, in rare cases, destabilize those sensitive dopamine pathways in the basal ganglia.
Triggering chorea.
Yes, triggering temporary chorea that typically resolves after delivery.
It also lists post-hypoglycemic chorea, meaning the motor centers were damaged by a severe low blood sugar event, and delayed post-anoxic leukoencephalopathy, meaning the white matter of the brain was damaged after a period of being deprived of oxygen, like after cardiac arrest.
And we absolutely cannot forget the nutritional and toxic causes. B12 deficiency is specifically highlighted in the text.
Something as simple as lacking a vitamin can cause complex fluid movement disorders.
Vitamin B12 is absolutely crucial for the maintenance of myelin, the protective insulating sheath that wraps around your nerve fibers.
Like the rubber on a wire.
Exactly. Without B12, that insulation begins to degrade, a process called demyelination. When the nerves in the basal ganglia lose their insulation, the electrical signals begin to misfire and crosstalk.
Leading to the uncoordinated fluid movements of chorea.
Exactly.
So a purely nutritional deficit frays the wiring of the brain. And finally, the text lists heavy metal poisoning, like mercury intoxication, and gross structural issues like cervical cord compression, where the spinal cord itself is physically pinched.
The scope is incredible.
It is astounding. You could be looking at a patient with a fluid, unpredictable movement disorder, and the root cause could be anything from taking a common antacid to a childhood strep throat infection causing friendly fire, to a B12 deficiency fraying their nerves, to a spinal cord compression. The intellectual detective work required of a physician is immense.
Which is exactly why having rigid diagnostic frameworks like our mental flowcharts and our deep understanding of the premonitory urge and suppressibility is the only way to safely navigate this landscape without getting hopelessly lost.
Okay, we have thrown a massive amount of deep clinical data at you. We have explored the mechanics of everything from brain chemistry to viral scars. It is time to cement this knowledge. Let's build some memory anchors and run through a few complex mini-case scenarios to test your clinical reasoning.
To permanently remember the two absolutely pathognomonic defining features of a motor tic, I want you to use a simple mental anchor. Think of the acronym US, like the United States.
US, okay.
U stands for urge, the premonitory urge. That rising, intensely uncomfortable physiological tension that demands release.
And the S?
S stands for suppressibility, the temporary suppressibility that allows the patient to hold the movement back, but only through immense, agonizing strain.
So if you observe a movement and it lacks either the U or the S, it is likely not a TKIT.
Keep that anchor in mind. Now let's test your clinical reasoning with some rapid-fire mini cases.
Let's do it.
Mini case 1. You are reviewing the chart of a 50-year-old patient who has resided in an inpatient psychiatric facility for the last 20 years. They have been on long-term haloperidol for the management of severe schizophrenia. The nursing staff notes that over the last month, the patient has suddenly developed multifocal tics, rapid blinking, severe grimacing, and occasional shoulder shrugging. What do you think?
Okay, let's walk through the clinical reasoning here. They are an adult with a new onset of tics. My flowchart tells me I would normally ask about a childhood history of Tourette's, but their medication history is screaming at me.
It is.
Haloperidol is a powerful first-generation antipsychotic. The long-term use perfectly aligns with the text description of tardive Tourette's. Even though they've been on the drug for 2 decades without this specific side effect, I know that the neurochemical adaptation, the dopamine receptor hypersensitivity, can be delayed for years.
Right.
The clinician must suspect the long-term medication is the culprit, rather than looking for a new brain tumor.
Your reasoning is flawless. You recognize the delayed fuse mechanism. Let's move to mini case 2. A 30-year-old patient comes into the neurology clinic. 2 months ago, they were in a severe motor vehicle accident and suffered extreme whiplash and physical trauma strictly to the right side of their neck. Now, they are presenting with a persistent, violent head-jerking motion.
Okay, I am visualizing the structural mapping we did earlier. Peripheral injury. The trauma was mechanical, located in the cervical nerves of the neck.
Go on.
The resulting sanatic is strictly focal. It is an isolated head jerk, not a full body or multifocal presentation. The clinical reasoning says this is a peripheral injury tic because the text clearly dictates that these Sanitics remain in persistent anatomical proximity to the exact site of the original physical injury. The damaged nerves are sending localized static, and the brain is answering with a localized release.
Excellent anatomical correlation. You mapped it perfectly. Let's look at the final scenario, mini case 3. An elderly patient presents to the clinic complaining of a severe movement disorder. They state that the right side of their face suddenly and violently scrunches up multiple times a day. You ask them to describe the moments right before the movement happens. They say, "I feel a sudden, terrifying bolt of lightning pain in my jaw, and then my face just contorts."
The critical word there is pain. Based on the physiology we unpacked, headaches are preceded by an uncomfortable urge, a rising tension, a strain, but they're absolutely not characterized by acute pain.
Right, pain is not part of the Descenic presentation.
The movement here is a physical reaction to the agony. Therefore, I run my differential and rule out a motor tic entirely. We diagnose tic douloureux, likely secondary to trigeminal neuralgia. The movement is merely a reflex wince to an excruciating neurological spasm.
You are operating exactly like a master diagnostician. You are isolating the underlying mechanism, not just observing the superficial visual symptom.
All right, let's lock this in completely. It is time for the self-test section. We're going to ask you 5 rapid-fire questions to test your new medical knowledge based strictly on the physiological and anatomical concepts we've covered from our sources. I will ask the question, I'll pause for just a second so you can formulate the answer in your head, and then I will provide the clinical answer and the reasoning. Ready?
Let's see how they do.
Question 1. What is the very first critical question you must always ask an adult patient who is presenting with a brand new motor tic? Take a second to think.
It's the most important question.
Answer. You must ask, is there a history of childhood Tourette syndrome? Because the neurological pathways of Tourette syndrome can go dormant, completely remitting for decades before reactivating later in life.
Spot on. Question 2. You are observing a sudden, simple muscle jerk in a patient's shoulder. What subtle physical sign, observable in the milliseconds following the movement, distinguishes a myoclonic jerk from a simple motor tic? Think about the relaxation.
Answer. A slow relaxation phase. Myoclonus is a raw electrical misfire that slowly fades out, causing the muscle to visibly wind down. A tic is a discrete motor program that snaps shut instantly.
Question 3. Which specific cranial nerve is structurally involved in a hemifacial spasm?
Answer. The facial nerve, also known as cranial nerve 7th. Because the pathology is tied to this single nerve exiting the brainstem, the spasm is strictly confined to one side of the face and never crosses the midline.
Question 4. If a patient describes a movement disorder by saying it feels exactly like they are trying to hold back a sneeze, what is your likely diagnosis?
Answer. A motor tic. The sneeze analogy perfectly encapsulates the overwhelming physiological demand of the premonitory urge and the immense exhausting strain of temporary suppressibility.
And question 5, an etiology challenge drawing from the systemic causes of chorea. Name one specific vitamin deficiency and one specific endocrine disorder that we discussed that can cause the fluid mercurial movements of chorea.
Answer. Vitamin B12 deficiency, which causes chorea by destroying the myelin insulation of the nerves in the basal ganglia, and hyperthyroidism, which alters the metabolic rate and electrical gradients of the brain.
Excellent work. You've successfully navigated the deep mechanics of clinical neurology today.
Let's do a rapid revision summary before we close out our rounds. We've learned that tics are sudden, rapid movements that resemble purposeful actions. They are physiologically defined by the US anchor, an involuntary premonitory urge, and a massive strain of temporary suppressibility.
And chorea, by contrast, is a fluid, lightning-like mercurial wave of movement that lacks both an urge and suppressibility.
Right. And diagnostically, we must remember that tics can be caused by recurrence of Tourette's, an astonishing array of medications, especially the delayed trap of tardive Tourette's from antipsychotics, or they can be the vanguard symptom of underlying choreiform disorders.
While chorea itself acts as a systemic alarm bell, warning us of vast bodily issues, everything from hormonal shifts in pregnancy or oral contraceptives, to the friendly fire immune attack of synonyms, to metabolic crises or structural brain infarctions.
It brings us to the ultimate goal of medicine, treatment. The text is brief but definitive on this philosophy. What is the clinical approach to managing these disorders?
The primary unyielding directive is always to treat the underlying cause first. You do not simply prescribe a heavy neurological drug to suppress a tic if the movement is actually being caused by carbon monoxide poisoning or a B12 deficiency, or an overactive thyroid.
You fix the root issue.
Yes, you remove the offending medication, you correct the metabolic imbalance, you treat the infection. Only when addressing the underlying cause is proven ineffective or structurally impossible does the text suggest consideration be given to the symptomatic treatments found effective in Tourette's syndrome, such as utilizing a second-generation antipsychotic to artificially suppress the hyperactive motor pathways.
Treat the fire, not just the smoke. I think that is the perfect guiding principle for any clinician.
I agree completely.
We're going to wrap up our clinical rounds here, but I want to leave you with a final provocative thought. Something to mull over on your own that builds on everything we've unpacked today about the mechanics of the human brain. Think back to the profound physiological reality of a tic. It is born from a rising, almost unbearable premonitory urge, a physical tension generated deep within the basal ganglia that demands a physical release.
A very real, very physical demand.
Right, and the patient can suppress it, but only through immense, exhausting willpower until their frontal cortex finally capitulates and they execute the movement to find relief. If that is the reality, where exactly does the boundary between an involuntary neurological reflex and a conscious psychological choice truly lie?
It's a heavy question.
If the subconscious brain creates an unbearable sensation that effectively holds the body hostage until it acts, is the body acting against the brain's wishes, or is the conscious mind violently forcing the body to comply to seek relief? When our neurochemistry demands an action, are we the victims of our biology or the accomplices to it? It is a profound question about the nature of free will, the architecture of the nervous system, and what it truly means to be in control of your own body. Keep pondering that. Thanks for joining us on this deep dive.